Hello, I'm Rahul, a junior doctor in the UK, and welcome to ECG Reviews. Today we have an interesting case of a 42-year-old female with a massive STEMI. Let's begin with the standardized system of rate, rhythm, axis, hypertrophy and infarction. We'll start off with the first three. So rate, you should pick the same place, so there to there. And we count the number of large boxes. So there's 4 large boxes plus a half there plus a half there. So we'll say 5. 300 over the number of large boxes is the rate. So this patient isn't bradycardic and they're not tachycardic. Now we move on to rhythm, which involves the PR interval and the QRS. Now the PR interval ranges from there to there. That's 4.5 small boxes. 4.5 times 40 is 180. Remember, we multiply by 40 because each of these small boxes is 40 milliseconds. As long as the PR interval is between 120 and 200, we're happy. The QRS ranges from there to there, which is 2 small boxes. 2 times 40 is 80. As long as this is less than 120, we're happy. So the PR interval is normal, QRS interval is normal. Now the axis. Now we start off with our circle. And the two best leads to look at are leads 1 and leads 2. So lead 1, the R is greater than the S. Remember, if it's positive, it points in the direction of the lead. So therefore, it lies in this side. Now, if lead 1 was negative, the axis would lie on this side. So let's shade in our circle. Now lead 2. So if we have a look, the R is greater than the Q wave, so therefore lead 2 is also positive, so it lies in this side. Remember, if lead 2 was negative, it would lie on the opposite side over here. So let's shade that in. If we have a look, our overlap is over here, which is in the normal range, so therefore the axis is normal. Now let's move on to ventricular hypertrophy. We'll start off with left ventricular hypertrophy first. So the two criteria that are used are the S wave in V1 plus the R wave in V5, and that should be greater than or equal to 35 millimeters. And the other one is the R wave in AVL should be greater than or equal to 11 millimeters. So we have a look. The S wave in V1 is approximately 1 large square, and in V5 it's about 1, 2, 3, 4. So in total we have 5 large boxes. 5 times 5 is 25. Remember, we multiply by 5 because one of these large boxes has 5 millimeters in it. 25 isn't greater than 35, so this is not suggestive of left ventricular hypertrophy. If we have a look at AVR, we see that this is probably about 4 millimeters, maybe 3, so this is definitely not more than 11. So therefore, there's no suggestion of left ventricular hypertrophy in this ECG. Now remember, this criteria is not very specific, but it's quite sensitive, so it's good at ruling out left ventricular hypertrophy. Now let's move on to right ventricular hypertrophy. So, in this case we look at V1 and V6. So in V1, we see if the R wave is greater than the S wave, or if the R wave is greater than 7 millimeters. In this case, the R wave is not greater than the S wave. Also, the R wave is probably about 4 millimeters, so it doesn't meet the criteria of 7. So therefore, there's no indication of right ventricular hypertrophy according to V1. If we have a look at V6, it's the opposite. So the S wave should be greater than the R wave. The S wave is not greater than the R wave here. Also, the S wave should be more than 7 millimeters. In this case, the S wave is not more than 7 millimeters. It's probably about 2. So therefore, this ECG, there is no indication of left ventricular hypertrophy, and there's no indication that it could be right ventricular hypertrophy either. Now let's move on to atrial hypertrophy. The best lead to use is lead 2. So if you remember that we have the right atria and we have the left atria. The SA node lies in the right, and it travels from the right to the left. Now, as you'd expect, with left atrial hypertrophy, this distance increases, so therefore you'd expect the P wave to progressively get larger. So we measure from here to here, and we see that there's 3 small squares. 3 times 40 is 120. Any P wave where the length is greater than 120 is indicative of left atrial enlargement. Now, right atrial enlargement depends on the height. So from there to there, we see that's about 1 millimeter. If it was greater than 2.5 millimeters, then this is indicative of right atrial enlargement, which it isn't. So in this ECG, there might be left atrial enlargement. Now let's move on to infarction. So infarction, there's 3 things to consider. First is Q waves, the next is ST changes, and then the last is T wave changes. We'll examine 3 leads at a time and examine for all 3 and then put them together at the end. So we'll start off with Q waves. Remember, the Q wave is a first negative deflection. Lead 1, there are no Q waves. Lead 2, there are Q waves. Now, is it pathological? It depends. Is it more than 40 milliseconds? Yes, it is. Is it more than 1/4 of the QRS depth? No, it's not, but it is about 2 millimeters, which does make it significant. So this is likely a pathological Q wave. Lead 3, again, that looks more than 40 milliseconds wide. This is deeper than 2 millimeters. It's not more than a quarter, but it is likely to be a pathological Q wave. Next, we move on to ST changes. So we find the J point, and we go about 60 to 80 milliseconds after, so about there. So we'll compare there to there, and I see that that's probably about 1 millimeter of ST depression. We also have an inverted T wave, or a biphasic one. Now we look at lead 2. So in lead 2, the J point is there, so we measure from there. If we measure that, that's about 3 millimeters of ST elevation. In lead 3, the J point is there, and we measure from there. So if we have a look, we see that there's about 4 millimeters of ST elevation in lead 3. Now if you have a look, lead 2 and 3, these are inferior leads. 1 and AVL are lateral. So of course we see that there's ST elevation in the inferior lead, so therefore 1 and AVL, these changes are likely to be reciprocal changes. So again, let's examine the next 3. Lead 4 you want to ignore because this is a rhythm strip. AVR is effectively a modified lead 2. If you have a look at it over here and here, it's effectively a modified lead 2. So don't check AVR for Q waves. AVL doesn't have Q waves. AVF does have a Q wave. It's 40 milliseconds wide and it's about 2 millimeters deep. So therefore this is likely to be pathological. So again, there's a pattern going on. The inferior leads seem to have Q waves and ST elevation. So let's have a look at AVR. J point is there, so we'll measure from there to there. So we see there's probably about 2 millimeters of ST depression. In AVL, there we measure from there to there. We see that it's about 3 millimeters of ST depression. In AVF, the J point is here, so we'll measure from about there, from there to there. See again, that's probably about 4 millimeters of ST elevation. So again, we see that the lateral leads, so AVL, has reciprocal changes to these inferior leads. So right now we should be suspecting inferior MI. Now let's have a look at the precordial leads. We'll start with V1 to V3. So are there any Q waves? No, no Q waves V1, V2 and V3. This is expected. Now ST changes. So V1, J point is there. So we'll measure from there to there. And we see that actually this is about 1 millimeter. Maybe 1.5. V2, J point is there, so we measure from there to about there. We see that this is about, again, 4 millimeters of ST depression in V2. In V3, J point is there, so we measure from there. Again, that's probably about 3 millimeters of ST depression. So we have ST depression in V2 and V3, no Q waves. Now, this is an ST elevation. So in this case, we have a posterior STEMI, and if you have a look, the posterior wall, let's imagine, is there. V1 and V2 are looking in front of it. If we put posterior leads from the back, so these would be called V8, V9, then we would see ST elevation. It would effectively be the reverse of V1 and V2. So really, even though we see ST depression in V1 and V2, this is actually ST elevation. And this is a posterior infarction. Now let's move on to V4, V5, V6. So again, V4, J point is there. We measure from there to there, probably about 1 millimeter of ST depression. V5, from there to there, no real change. V6, there to there, maybe 1 millimeter of ST elevation. This is probably not significant. So now let's put this all together. So rate, 60 beats per minute. Rhythm. The PR interval was between 120 and 200, so this was normal. The QRS was less than 120, so again this was normal. Now there's two other things you want to look at when you look at rhythm. The first one is regularity. Now we'd have to go quite far back, but remember this rhythm was regular. Also you want to see if it's sinus rhythm. Best way to do that is have a look, see if all the P waves are the same. They look about the same to me. and see if they're upright in 2, 3 and AVF. So in this case they are upright and they all look pretty much the same. So therefore this is a sinus rhythm. Now axis. Remember the axis was normal. So we've done rate rhythm axis. Hypertrophy, there was no suggestion apart from left atrial enlargement. So possible left atrial enlargement. Remember that any sort of hypertrophy has to be confirmed on an echo. You can't really confirm it using an ECG. An ECG can only be suggestive. So we've got rate rhythm axis hypertrophy. Now with infarction, as we discussed, we have an inferior STEMI. If you have a look at this diagram, 2, 3 and AVF all had ST elevation. Remember 2, 3 and AVF are your inferior leads as they're literally inferior to the body. 1 and AVL are lateral as they're literally lateral. Inferior STEMI with posterior extension. Anytime you have any ST depression in V1 to V5, suspect a posterior STEMI, especially in the context of an inferior STEMI. So this is our final diagnosis, inferior STEMI with posterior extension. Thank you for listening. I hope you enjoyed this quick ECG review. If you enjoy this sort of content, please do subscribe as there'll be more coming. Thank you.